I did. Sydney, I saw Sydney. Hello, everyone. My name's Renee Barabo, and I work with Conscious Health that is sponsoring this event today. And I'm also the chairperson for Emerging Themes in Behavioral Health. And Dr. Brad Zehring is actually part of our Emerging Themes in Behavioral Health program. And it's a little bit of a taster so you can get a sense of what we have coming up. Emerging Themes in Behavioral Health. This is the third anniversary. It's from April 17th through the 19th at UCLA in Los Angeles, and it's become on the West Coast a premier behavioral health care conference because for me, what's been really most important is that it maintains a clinical excellence. And so we've been really well supported by UCLA. In fact, today I was looking at the registrations and we have lots of the medical students coming, which is like really, really cool because, to cross that bridge between the medicine and the miracles that we know in treatment is huge. On the slide here is some of the great presenters we have. And remember, Dr. Brad Zehring's one of those presenters, and he's here with you early. Dr. Christy Gibson, Dr. Sabine Hassan, Dr. Anna Yusum from Yale. We have Dr. Robert Weiss. We have Dr. Alfie Brand Noble, Gail Wyatt from UCLA, Dr. Cho Tafur, who's also a UCLA medical doctor, Paula Williams. I mean, this lineup goes on and on. I'm very, very excited about it. And I hope that no matter where you are, it's not too late to hop on a plane. Spring is beautiful in LA. And and if you come here today and you want to attend the conference, just drop me a line, hit reply, and I will give you a $100 off gift certificate for coming to today's conference and making that plunge into joining our conference in Los Angeles. And if you think you're going to come, please get your hotel rooms today because I hear the hotel is full and we're on the last couple of days of our room block. Somebody raised their hand. Let's see. Oh, if you have a question, this is just a little housekeeping. If you have a question for Dr. Brad, please put it in the Q&A. We'll be mining the chat, but that's more for, a little conversation. But Q&As I would definitely be looking at. And Genesis, the co-conference assistant, is here. She is going to help me look through those, and just in case that I missed them. Well, first up, I would like to introduce my boss, J.D. Kalmanson, who's a Yale Shabbat scholar, a skilled facilitator, teacher, counselor, speaker, who has previously provided chaplain services to the prison, local groups, and remote villages throughout the world. JD is the founder and CEO of Montare Behavioral Health, Renewal Health Group, and his newest passion is Conscious Health and Wellness, who is the sponsor of today's talk. JD, are you here?
I am. Thank you so much, Renee, for the beautiful introduction, and really so grateful for putting this wonderful event together. This is your brainchild, and for Dr. Z, who is going to give us a really robust and comprehensive educational presentation on something that is so timely. We keep hearing about ketamine, and just a little bit about conscious health. Conscious health was the vision and the dream of a few of our core team members who noticed a critical gap. With regards to our physical, medical health, so many of us are deeply invested with our time, with our finances, whether it's working out in the gym or the host of other amazing sort of interventions that we're all doing to keep our bodies feeling good and alive. But there was, unfortunately, not as much time, effort, and resources dedicated to our wellness and to our overall well-being. And so enters Conscious Health, which is a neuro-wellness sort of spa that we not only treat diagnoses, the traditional ones like anxiety and depression and mood disorders, but there's also an aspirational peak performance quality that whoever comes in here leaves with a sort of renewed sense of mission and purpose and feeling more alive than the way they came in. And so on that front, we provide all forms of ketamine with different delivery methods, the Spravato, the intranasal, the oral, and soon we'll also be providing the IV ketamine. And they say I'm sure have a lot of clinicians who are plugged in today. I see over 151 participants. And they ask the question, how many clinicians, therapists does it take to change a light bulb? And the answer I heard was one, but the light bulb has to want to change. And whoever of you are therapists, you can relate to that. The ketamine I've seen firsthand with so many of our clients who come in and they know they're supposed to change, but they're lacking that motivation, treatment resistant depression. And the ketamine really helps as an opener. And then coupled with our therapeutic guidance with the integration, the exponential efficaciousness is really something special to behold. And then we also have the transcranial magnetic stimulation, our conscious retreats in our lovely campus out in Malibu, and then EMBP therapy, which is a little bit out of the scope of today, neurobiofeedback therapy, and then psychotherapy as well as telemedicine. So that's a little bit about conscious health. If you're located in LA or in the area, check us out. It's a really special, innovative, refreshing type of atmosphere to get better at. Without further ado, I want to introduce our Chief Medical Officer, Dr. Brad, who is not only a dear friend, he's also one of the most compassionate and competent doctors that I know. He established Conscious Health with a desire to deliver expert psychiatric treatment for individuals who struggle with mood disorders, anxiety, attention disorder. And throughout Dr. Zehring's trainings, he has seen the gaps and the lack of psychiatric care available for individuals with these disorders, and he aims every single day to provide a better path forward. Dr. Zehring believes the psychiatrist needs to understand the biological, psychological, social, and spiritual causes that contribute to creating and maintaining health and to address them accordingly. Without further ado, Dr. Brad, we're so grateful. Take it away.
Thank you, JD. Thank you, Renee. We'll switch screens here. All right. So I'm going to share my screen. Well, welcome everybody. I'm glad that you're here and can make this. We're going to talk about ketamine today and really the importance of just really understanding what ketamine is. But I've also titled it The Next Frontier in Psychiatry because we're in a new stage of psychiatry. We need more treatment options that are going to help our patients. And psychedelics is kind of the one area where it's showing a lot of promise. Ketamine is the first one that we're watching, monitoring, and moving forward with. And really how well we use this and do with this as a social construct, as clinicians, as patients, as everybody involved is really going to help usher in, psilocybin, MDMA, kind of these other next lines of treatments that hopefully we can be entrusted with and really do well for our patients. I'll talk about the objectives. This talk is going to be about 50 to 55 minutes. I always like to give people an understanding of how long it will be so you guys can feel comfortable and know when to expect it to be over and kind of just have an understanding of it all. We're going to talk about ketamine, what it is, where it came from, and why is it now in behavioral health, and what's the importance of it being in behavioral health. I'm going to talk about its mechanism of action and its therapeutic benefits. We're going to look at, once we understand those things, who are ideal patients that we should be focusing on giving ketamine to, and perhaps who are patients that we want to have a critical eye toward or maybe not give ketamine at all to. Understanding there's contraindications. This is a drug, and while there's a lot of positivity around this, there's a lot of excitement around it, we have to understand all components of it. And like any drug, especially psychoactive drugs, there can be risks and abuse and things that we need to be aware of. So we'll talk about that a little bit. Throughout the whole talk, I'll focus in on where the gaps of research still are. Ketamine is still, even though it's been around a long time for medical use, really the 2000s are really the behavioral health use of it. And so research in those domains are still up and coming. And then we'll talk about some causes for concern. So I have no financial disclosures, no conflicts of interest. At the beginning of talks, I like to give a sneak peek, and this is kind of just the 30,000-foot view of the talk. Systematic reviews, meta-analyses, if there's anything that the scientific community agrees upon close to 100%, is that ketamine is showing robust, rapid, antidepressant effects, anti-suicidal effects. It really has done a great job at that. Evidence for other indications at this time are less robust, but there's a lot of still positive momentum. We just need more understanding and more research to validate what we're seeing clinically and anecdotally. Optimal dosing, routes of administration, and the most effective forms of adjunctive psychotherapy need to be examined further. And then conclusions on studies, on research need to be interpreted with caution because of high risk of bias of included studies. So what is ketamine? So ketamine is known as a dissociative anesthetic, and it was really born out of a need for a better type of anesthesia drug. The drug that was used until the early 1960s was PCP. And yes, that's the abused PCP that we're aware of. And what they noticed about people coming out of surgery when they were using PCP for anesthesia was violent behavior, hallucinations, distorted perception of sound, and even in an emergent delirium, which is an altered consciousness coming out of surgery. And so anybody who's had surgery or has treated patients post-surgery, that's not an optimal space for patients to be in. Ketamine was approved in the USA for medical use in 1970. We'll look more at that. And then investigation into behavioral health started in the 1990s. But as we're going to see, the medical use showed some positive behavioral effects even back before 1990. Ketamine is an NMDA receptor antagonist, and that's where most of its psychoactive effects are going to happen. But it works on many other receptors, as we'll look at. It's still the drug of choice for short-term procedures when muscle relaxation is not required, and is different than other anesthetics in that it suppresses breathing much less than most others. So ketamine remains invaluable to the fields of anesthesiology and critical care medicine. It's a very stable medication for these types of disciplines. Once it became FDA approved in 1970, it moved to surgical anesthesia in the Vietnam War, and it's still used in veterinary medicine. And then the street drug, the ketamine is a drug of abuse, and the street drug names are Special K and Cat Valium. So let's look at the history of ketamine, really the progression of ketamine to today. So in the 1960s, there was a professor, Calvin Stevens, that synthesized ketamine in 1962. It was tested on animals, showed promising results, and then used on human prisoners in 1964. And what they found in these early trials was that ketamine acted faster and reduced toxic behavior, which created a much better space of anesthesia than PCP was providing. Further, later in 1960s, two professors from the University of Michigan, one in pharmacology, one in anesthesiology, published their reports of their clinical experiences, and this was through 130 patients, wide age range, undergoing 133 surgical procedures. And what they noticed were a couple things. One is it did what it needed to do medically for anesthesia. It provided altered consciousness, but it also gave this limited duration of effect, which meant that if a procedure was 30 minutes long and they gave enough anesthesia for 30 minutes, and then the surgeon's like, well, we need to do 15, 20 minutes more. Instead of having to give another anesthetic that would snow somebody for another hour to 2 hours, you can give a limited dose of ketamine and give them that extra 15, 20 minutes. So it really helped individualize those cases for them. And what they saw in addition to that was minimal side effects, and patients coming out of anesthesia were much more stable, which provided significant benefit. 1970s, so from these promising trials, FDA approved it in 1970 for medical use. We talked about how the Vietnam War, this is where it's really being used on humans for the first time, collecting a lot of data from this. With anything else, as drugs become more widely available, especially psychoactive drugs, they can start to be abused. And we start to see this in the 1970s, starting in the West Coast and moving eastward. But also during the 70s, with the medication being used, psychiatric and academic research on ketamine had already begun. The 1980s ushered in even more illicit use, definitely in the subcultures of raves. And so it became ketamine, Special K became a very popular rave drug, and different forms of ketamine were being created. So definitely a big groundswell of abuse happening. 1990s, the conversation was, hey, this is getting out of control. There's a lot of illicit use happening. And during all this time, though, it's still being used medically as an anesthetic and still doing really well. Kind of as a side note, Hong Kong still struggles with ketamine use, illicit use today. But due to kind of the widespread illicit use and trying to get a control of it, the United States in 1999 put it as a controlled substance. And so what this did coming into the 2000s was when it became a controlled substance, it really decreased how it was being used medically and illicitly. So there was a good and probably not so good after it became a controlled substance. However, for the medical community, for the behavioral health community, the cat was out of the bag. And medical professionals began to really, in the beginning of the 2000s, research this more. What they were seeing was too much to be ignored. They had seen their patients struggling for a long time and finally had seen something that was working quickly and was being helpful, especially for depression and suicidality. So this led to more physicians prescribing this off-label. And we have started to see in the early 2000s, mid 2000s, this surge of ketamine clinics moving out throughout the country. Kind of what tipped this over even quicker into the public consciousness and the public conversation was in 2019, this became FDA approved in the intranasal form called S-ketamine. And so anybody that was maybe a little apprehensive to try something off-label, not FDA approved, as soon as something got FDA approved and people are like, what is this S-ketamine? Oh, it's ketamine. And then trying to figure out what the differences and what they are really increased the perception of ketamine and really increased how it was being given. Due to the success of S-ketamine and ketamine in general working, the FDA has also fast-tracked currently 2 other drugs that are based on ketamine to treat depression. And through all of this, it's important to always know this is still being used medically, especially in the fields of anesthesiology and critical care. So we're understanding the progression of it, and we understand how well it was used medically, but why behavioral health? And a lot of this is because we know that the burden of psychiatric disease has been significant. We know we've had limitations in psychiatry. We've been looking for other options for a long time. We're going to continue looking for other options. Patients in front of us, sometimes as clinicians, I know there's a lot of you out there, can feel powerless at times, hopeless at times with people sitting in front of us. And then what we saw with COVID was an increase in the challenge of the mental health burden. Another thing that happened during COVID is the DEA relaxed the controlled substance requirements. And so what we saw was ketamine clinics opened that were sending oral medications to people's homes and then following up virtually. And now I don't necessarily, I think ketamine needs to be more controlled and more supervised than that. It did get oral ketamine out into the public consciousness now. So now we have IV, which started, we have intranasal ketamine, and we have oral ketamine all being used in the public. And during COVID, right, we're seeing increase in mood disorders, increase in substance use disorders, increase in patients talking about PTSD. And so we know that there has to be more options for us. In addition to all of this, before the pandemic, suicidality had been increasing. We've been focusing on that. 2018, there was a survey that twice the number of adults said within the last 30 days increase in suicidal thoughts. Almost 46,000 Americans were dying by suicide by 2020. And so we have a real problem that we know we have to fill. So we know that we have an issue. Why do we have the issue in terms of lack of treatment or problems with treatment at times from at least a biological, pharmacological standpoint? So ketamine, like probably a perfect storm for this to come onto the scene right now, right? We have a sharp increase in psychiatric disorders. We have an increased public interest in mental health. And then we have this promise of this therapeutic value in depression and suicidality. And I keep saying those two because that's really known, but we're going to talk about how there's other effects for ketamine as well. And really the primary problem that ketamine was designed to solve is this idea of treatment-resistant depression. Treatment-resistant depression can affect up to 4 million American adults. And treatment-resistant depression, what it is, it's major depressive disorder. And up to 30% of those people, and it's probably underreported, but 30% of those people have treatment-resistant depression. Treatment-resistant depression has a variety of definitions. Probably the most solidified definition is somebody who has tried 2 antidepressants of adequate dose and duration. So they got enough of the dose, so it wasn't just a starting dose, and they took it long enough, typically 6 weeks, but longer. So you guys probably know a lot of patients. Most people are trying 5 to 10 medications throughout their life. 2 medications is kind of pretty standard. And so there's a lot more. So there's a lot of hopelessness that people have had from this. And not only are they trying multiple medications, not getting relief from those multiple medications, but when we try a different one, it can take multiple weeks for it to take effect. So we're not completely sure that it's going to be helpful, and then we're going to wait and to see. And then if it's not, so there's a lot of this time frame that we're watching with that. Not to mention there's side effects to all medications or potential to have side effects, and so weight gain and sexual dysfunction are common side effects with these medications, and not desirable. Conversely, we have this sub-anesthetic dose of ketamine. And when I say sub-anesthetic, so there's the dosing of anesthesia, which is much higher ketamine dosage. And then you have the sub-anesthetic, so lower doses that we're using for behavioral health that's showing rapid, robust, and sustained antidepressant effects, especially in patients with treatment-resistant depression. Right. So when you look at a lot of studies, some of the studies I've put down here is that up to 50% of patients with treatment-resistant depression have a significant decrease in symptoms 24 hours after a first IV sub-anesthetic dose. Now, when I say IV, I could have put other articles in here about intranasal has similar responses, oral has similar responses. Just a quick note about the research. Since IV has been out a long time, we got a lot of data on that. Intranasal has been FDA approved, so we got a lot of the data that supported that. And then since it's also been out since 2019, we've getting more data there. Oral, since COVID has started, we're starting to get more on that. So some of this will be just the way it is with the level of research that we have gotten so far. But 50% reduction, and typically when you hear patients come after their first session and you meet with them before their second session, they're talking about, I felt so much better, or I didn't know that I could still feel that way. And so it's an immediate effect that brings a lot of hope for the person, a lot of hope that they've been lacking for a long time in many cases. So there can be a lot of confusion about ketamine. Like, what are all the different types of ketamine? And really, when people say types of ketamine, it's what's the route of administration? Which way are they going to take it? We'll talk about that. We'll talk about the mechanism of action, and we'll take a little bit of a dive into neurobiology to understand the therapeutic effects. I didn't go terribly deep into this, as it could have been a whole other talk, but it's going to be some in there that we get a general gist of what we think is happening therapeutically. And then we're going to get a little bit of an understanding on dosing. So what is ketamine? Ketamine, we talked about, was the anesthetic. It can create dissociation. It's an enantiomer. So it's 2 molecules that are mirror images of each other, an R and an S. So they're identical when they're mirror imposed. Superimposed, they're different molecules, but if they're reflected in mirror, they're the same. And they're racemic. Racemic is equal parts. So 50% R, 50% S is IV ketamine, oral ketamine. That's the makeup. Intranasal ketamine, the one that was FDA approved as S-ketamine in 2019, is just the S form of ketamine. So it does not have the R form. The reason that this is that the S enantiomer of ketamine has a stronger binding affinity for the NMDA receptor than its R counterpart. Another reason that's out there, maybe a little bit more cynical, is ketamine in its basic form is cheap to make. If you brand it and you make it FDA approved, then you can sell it for more money. And so that's one way, but insurance also can cover this as well. So there's that. But it is just the S form of ketamine. For FDA approval, they had 31 global clinical trials. And one of the good things about FDA approval is there's going to be a procedure and protocol in place. And so there's the REMS program, which is a risk evaluation and mitigation strategy. And really what this does is it puts guardrails in place. So any clinic that's going to prescribe Spravato has to be part of the REMS program. And so it's something that we have and that we follow, and it's the same for every single patient. Even though ketamine is not FDA approved and S-ketamine is FDA approved, they're still both controlled substances and still need providers with DEA licenses to prescribe both of them. Just a little bit more distinction about the different routes. IV ketamine can be a little bit easier to control the dose and the bioavailability, meaning anytime we put something right into the system, so IV intramuscular, you're bypassing the liver to metabolize it. So if you take something orally, intranasally, even rectally, it has to go through the liver. Liver metabolizes it some, and so it takes longer to get to the bloodstream. So that's one advantage of IV. Oral, as we talked about, IV can be expensive. Insurance most of the time is not going to cover it. Can be expensive. Intranasally, insurance can cover it, but insurance companies are having their own definition of what they're going to do to cover it. And if it's not covered, it's really expensive. Oral kind of fits this middle ground of, we know that it's working, it is ketamine, and it can be cheap. Compounding pharmacies, we can get it cheaper and we can monitor it with the patient. So this is a big slide, and really what I'm showing you here is that ketamine also is known as a dirty drug, and that doesn't necessarily bring a negative connotation, but what it does, the nomenclature means that when a drug hits many receptors, it's meaning it's having many effects. And so the more effects that a medication have, the more side effects it can produce, the more that we don't understand about it. What are the downstream effects? What are the metabolites? Kind of all these things are brought into the conversation. And so there is still a lot that we're going to need to understand about it. But I just want to show you a couple of them. So the top here is NMDA receptors. We talked about that. Ketamine's an NMDA receptor antagonist. This is where the psychoactive effects are happening with the ketamine. And then if we look at the bottom under the agonism section, we see opioid receptors and AMPA receptors. AMPA receptors is probably where ketamine's acting upon to have some of the antidepressant effects. And then the opioid receptors is an interesting conversation. Ketamine and substance use, we worry about abuse, obviously, as we've seen, and we're going to see further, but there's also research into, are we going to be able to help patients with substance use with ketamine? Additionally, patients with alcohol use disorders, opioid use disorders, even patients with self-harm are on a medication called naltrexone. And so we have to be aware of that. If they're taking naltrexone blocks the opioid receptor. And so ketamine is going to have less of an effect on a patient taking naltrexone. So let's look at therapeutic benefits a little bit. And so hang with me on the next few slides. We're gonna have a little bit of neurobiological jargon. I'm gonna try to break it down as best that I can. But it's important to really understand why ketamine's working and the benefits that it's bringing. So we see ketamine over here on your left side of your screen, and then the impacted systems that are in the middle of the screen. And the impacted systems, some of them, monoamine system is where your traditional antidepressants are acting. It's your serotonin, norepinephrine, and dopamine, kind of the traditional neurotransmitters that we've heard about. Opioid receptors, GABA receptors, so GABA is where benzodiazepines act on. Glutamate, we're going to talk more about glutamate, but glutamate's the most numerous neurotransmitter within the brain. And then neurotrophic factors such as BDNF, and we'll talk about that. When ketamine's working on all these symptoms, it's increasing synaptic strength. It's increasing the connection of all the neurons in the brain, creating a more healthy place of the brain. It's restoring communication, if you will, which then helps decrease anhedonia, decrease despair, decrease suicidal ideation. So we're coming to understand that ketamine is probably acutely increasing hippocampal proteins that are helping explain the antidepressant effect. I'm sure a lot of you have heard about BDNF, brain-derived neurotrophic factor, and maybe less of you have heard about mTOR. But BDNF is an important role for neuronal cell survival and growth. And so this is really helpful for communication between nerve cells, and we can increase BDNF naturally. Sunlight throughout our day, social connections, good sleep, good eating patterns, exercise, things that are healthy for the heart and brain are going to help increase BDNF production. So conversely, somebody's depressed, isolative, not sleeping well, not eating well, using substances, BDNF is going to be low, not going to be good for neuronal survival or growth. So ketamine's helping increase this. mTOR is important for kind of keeping the homeostasis of the cell, if you will. So it's regulating cell proliferation. We don't want cells just proliferating out of control. We need guardrails for that, because if cells proliferate out of control, that's cancer, right? Autophagy, think of as recycling. mTOR is going to come in and help recycle parts of the cell that are no longer needed, that are old, that are just destructive, that just don't need to be there anymore. Let's recycle those. Let's get those out of there. And then apoptosis. Apoptosis is a term that just means programmed cell death. And so throughout our biology in our bodies, we have cells dying all the time, and we want cells to die. We don't want old damaged cells. Again, that leads to bad pathology. So beyond these proteins, ketamine's also probably, and this is the last bullet point here, ketamine's also probably producing epigenetic changes in our system. And epigenesis means external factors coming and changing our DNA, changing the way our DNA is expressed. Old dogma was once nerve cells died, they were dead, they couldn't regenerate. We now know it's very accepted that nerve cells die and regenerate, and we can do things to help nerve cells regenerate. Ketamine being one, exercise being one, right? All therapeutic processes, mindfulness, meditation, these all help it regenerate. And so ketamine is also probably helping in this process, which is exciting. This slide is going to talk about dissociation because we're still trying to understand dissociation and ketamine's role in it, right? We know that the brain and body can disconnect from the environment while maintaining an internal generated experience, right? We see this in pathology, trauma, shock, things that the brain's going to do to keep the body safe. But psychedelics can do this as well, and this is what ketamine's doing. Now, how we get to that dissociative state, we know that the NMDA receptors have probably a part in this, but the cellular and circuit mechanisms more deeply are still hard for us to understand, and we're trying to figure out more. There was an interesting article published in Nature Neuroscience in 2023 last year, where in mice, they saw that ketamine caused spontaneously active neurons to become suppressed and previously silent neurons to become spontaneously activated. Now, what the interaction was or what the importance of that isn't fully understood, but I think this is exciting from a neuroplastic state, from a state of how we know through neuroimaging how the brain looks when pathology is present versus how it looks when it's healed. And so this is probably another area where ketamine is working. Researchers at Mass Gen recently traced ketamine's effects to 3 brain regions, 2 probably where the antidepressant effects are happening, and then 1 where the dissociative effects are happening. And where the antidepressant effects are happening is the prefrontal cortex and the hippocampus. And the hippocampus is important for memory formation. That's where memories are stored. And this is important, which is kind of the segue to ketamine in my philosophy and in conscious philosophy and how we go should not be a standalone treatment. I think, as I'm going to show you, literature helps support this idea as well. We don't want people just coming for ketamine and then leaving, right? Ketamine needs to be a whole experience where we're working with their memories, we're working through the process. So there's a psychotherapeutic adjunct to this, there's a meditative adjunct, a mindfulness adjunct. There's a really intentional, holistic space to kind of hit this from all angles. And then with the prefrontal cortex, it also makes sense that an antidepressant effect is going to work on the prefrontal cortex. Where the dorsolateral prefrontal cortex is already where we focus transcranial magnetic stimulation for antidepressant effects. And then stroke. If somebody has a stroke in the left side of the frontal cortex, we know that the left side of the frontal cortex is damaged. And post-stroke, there's an increased risk that they're going to have depressive symptoms due to the damage on that side. Conversely, if they have a stroke, somebody has a stroke on the right side of the frontal cortex, post-stroke, there's an increased risk of manic symptoms happening. So we know that there's a lot of mood-centered responses in the prefrontal cortex, and that makes sense that that's probably where ketamine is acting a lot for the antidepressant effect. The third part, located in the back part of the brain, the posterior medial cortex, is probably where we're seeing a lot of the dissociative effects. But again, this is still moving forward in our understanding. I told you we'd talk about glutamate, and here's the slide for that. Glutamate, again, the most numerous neurotransmitter in the brain. It's kind of a really exciting neurotransmitter that's being studied a lot these days. Glutamate, just like a lot of neurotransmitters, is responsible for how neurons communicate with each other. And there seems to be a dose dependency between ketamine and glutamate. So at higher doses, ketamine seems to block glutamate, making it an effective anesthetic. And at lower doses, ketamine is probably enhancing glutamate production. So this has a variety of effects. One is it's, again, causing some of this dissociation effect. But 2, and in my mind, probably the most important thing, it's helping build connections and synapses between neurons. So this is important when we're talking to our patients. Often patients will say, or patients believe, it's not working, I didn't feel anything, or I didn't have a trip, or I didn't have dissociation, or I didn't have these things. And what we have to remind them, and most importantly, hopefully remind them before we even start ketamine, is that ketamine is working, whether whether you feel it or not, right? Behind the scenes, it's laying the groundwork, if you will, of the neurons to regenerate, to heal, and to communicate with each other between there. And that's really the important thing, because the more that you get those neurons healthy again and talking again and communicating again, everything else that the patient's going to be doing is going to be better. So this is really important, because we know when somebody's really depressed or even stressed for a long time, the brain is feeling the weight of that destruction, if you will. Those nerve cells are being damaged, and ketamine, along with a lot of other things that we've talked about, help repair those and help the brain into a better homeostatic state. So we're going to switch to dosing, and this slide just helps us remember, okay, there's different routes of administration that ketamine can have, and we've talked about the top four. We're not really using rectal form or subcutaneous forms right now. The dosing is a wide range, as you see here. Bioavailability, this just means IV and IM are going to be more available to the body right away, because they're not going through the liver for metabolism initially. But when we're looking at Tmax, which is peak concentration of the medication working, we're dealing with minutes of a difference between IV, IM, intranasal, and PO. So PO just means oral, which means that it's semantics really in what we're having, but we just need to understand this from a psychopharmacologic aspect. So then there is this debate, and the debate has increased. When should we use oral ketamine, intranasal ketamine, intravenous ketamine? I would say the preponderance of evidence probably right now is that IV ketamine is the way to go, but that's because it's been around a long time, right? S-ketamine has shown, into the intranasal form, has shown a lot of success, and the oral ketamine, through the research that's being published, has shown a lot of success. It's probably a step too far to say ketamine is ketamine, because these are different forms and different routes of administration, but it's ketamine, right? And we're seeing the positive effects from it. So some studies show that infusion of ketamine is more effective than the S-ketamine nasal spray. And maybe this is because maybe the R side, remember the intranasal doesn't have the R enantiomer of ketamine. The R is more efficacious and longer acting in treating patients. And so some of this early evidence has led articles to argue, in serious circumstances, patients should receive IV ketamine whenever possible. However, as we're going to see moving forward here, because I'm going to deal more with what studies are showing, you could be going down the road looking for evidence of one thing and see contrast in something else that you're looking at that contradicts what you just read. And so there are other articles that show IV and intranasal ketamine were each shown to have reductions in suicidal ideation with 24 hours of administration. So we have to understand that there's going to be bias in these articles, placebo in these articles, lack of research, not meaning that it's not working, but just lack of research to help confidently state this is the exact one that we need to use. No other should be used. So with dosing, I'm putting the dosages here not as you should take this as gospel and this is the dosing that you need to use. This really needs to be kind of your facility standard, kind of what you guys have talked about with your medical professionals, and kind of what your kind of established plan of action is going to be. But these doses are kind of pretty much in the middle of what's being done out in the community. So with oral ketamine, 2 to 2.5 milligrams per kilograms is kind of where we're at. Now, that can be given once a week, a couple times a week. There's kind of no consensus on that. But studies have shown smaller dosing options than that, larger dosing options than that. With IV ketamine, you have 0.4 milligrams per kilogram to 0.5 milligram per kilogram over a 40 to 60 minute period of being infused, with about 0.7 milligrams per kilograms being the max. Typically, you'll give 2 infusions in the first 3 weeks, so 6 sessions total, and then you kind of reassess and move on from there based on how the patient's doing and kind of what the next steps would be. Again, there's smaller dosing being used and there's larger dosings being used. And then intranasally, we have the procedure and protocol out by the FDA. There's 2 dosing options, 56 milligrams, 84 milligrams into the nasal cavities. There's an induction phase, which is 2 times a week for the first month, and then once a week for the second month, and then every other week for the third month. We stop after 3 months. There's really, that's probably the most popular out there, but there's really no strong indication of why should we stop after 3 months or not. So, but we're stopping at the 3 months. But in general, for all of this, further empirical work is required to confidently assert an optimal mode of ketamine administration, both the route and the dosing. and why I think it's always a good option to start low and go slow. It's kind of the theory of all medications anyway. You start at a low dose and you move up slowly, because as you see here, even at doses lower than I just talked about, patients can experience perturbing, unwanted dissociative symptoms. And this can look like feelings of intoxication. They can have the visual, auditory, somatosensory hallucinations or feelings of depersonalization, derealization. They can have ideas of reference and delusions, or they can even have some negative symptoms such as poverty of speech. So as you can imagine, this could be something that could be frightening for the patient and unwanted. Maybe they don't come back for treatment or don't want to continue treatment. So when we continue this talk on dosing, what we want to think about with lower doses, ketamine is going to have a lot of stimulant effects. This is one area, as we're going to talk about, why we monitor blood pressure, why we take in their medical stability. But also this is where they can experience some mild dissociation, hallucinations, distortion of time or space. So they're gonna have some of that psychoactive component. At higher doses of ketamine, we're really gonna start getting into more severe schizophrenia-like symptoms and perceptions that are completely separate from reality. Most of the symptoms that somebody's gonna feel is gonna resolve within 2 hours post-dose, post the infusion. However, I think a pause for concern here is how long should we be giving ketamine? Because there is some discussion and reports of long-term pronounced persistent neuropsychiatric symptoms such as schizophrenia-like symptoms, cognitive impairment, poor psychological well-being. So this doesn't say that we need to stop everything, but it just gives us a framework of we need to at least be understanding that these types of things can exist and really be monitoring and move forward cautiously. So knowing all of this, inclusion criteria, who are patients that we should think about giving ketamine to, exclusion, who should we not be thinking about giving it to, or thinking about not giving it to, and then risks that are associated with this. So as a reminder, it's being used medically and psychiatrically, right? And these are all the areas that it's being used, and it's used pervasively, right? And so we're going to focus on the psychiatric component of it. So for the past 2 decades, right, we talked about this: ketamine, antidepressant, anti-suicidal. We've noticed that. And then from that, since we've been so desperate as clinicians and patients to feel better, it's been used in other areas. But when we look at the meta-analyses and the systematic reviews, major depressive disorder, treatment-resistant depression, suicidality is a slam dunk. And then there's less synthesized literature across other psychiatric uses. However, off-label prescribing of ketamine for a large number of psychiatric disorders continues. Just the synthesis of data isn't fully there. And as a clinician, right, we're always taught do right by the patient, always think about risks. I mean, we're the ones prescribing this medication. And in fact, a couple of weeks ago, there was an article that came out from MedPage Today titled "Ketamine Clinics Diverge from APA Recommendations." APA, in this case, stands for American Psychiatric Association. And a couple of the bullet points are from the article were: proliferation of ketamine clinics in the US have veered far off course from the recommendations of the nation's premier psychiatric association when it comes to using the anesthetic to treat mood disorders. And then Dr. Friedman, who is a former editor of the American Journal of Psychiatry, cautioned that the booming use of the drug without enough guardrails to ensure patient safety could ultimately spell its end in psychiatric indications. And I think this is, for me, is the most important thing. We want to be doing the right things for the right reasons with ketamine because we want this to continue. We want other psychedelic medications that have shown the burden of proof and have shown to be efficacious and doing good. We want those to continue. And we want to make sure that we're always thinking of the patient first. That's the only interest that we really need to be thinking about. And we want to make sure that we're doing everything we can to surround that thought. So the patients that we're definitely going to think about ketamine to are major depressive disorder and treatment-resistant depression. Really, the delineation there is the medication trial. So that's the definition of treatment-resistant depression. And insurance coverage. So if somebody's going to need to get insurance coverage of ketamine, they have to have this designation of treatment-resistant depression. This doesn't mean that if somebody has major depressive disorder and maybe they haven't tried any antidepressants yet because they don't want to, that would not disqualify them for ketamine. It's just they're going to be paying out of pocket for that. It's not going to be covered insurance-wise. So that's a little bit of the distinction there. Somebody with acute suicidal ideation, we're thinking about ketamine. And then I asterisk PTSD and anxiety spectrum disorders. PTSD probably has the most burden of proof after depression and suicidality, but it's still emerging. our understanding of ketamine and PTSD, and then anxiety spectrum disorders likewise. So before ketamine, what did we do with treatment-resistant depression besides trying a bunch of other different medications, right? There's transcranial magnetic stimulation, but there was also ECT, and electroconvulsive therapy was the gold standard, is the gold standard for treatment-resistant depression. However, ECT, even though it is effective, can come with a lot of, can come with side effects that can be significant and time. There is anesthesia that is used in ECT. And so there's some thought of what if we use ketamine as the anesthetic for somebody with ECT, because the anesthetic helps put them under enough to induce the seizure. But there's been no sufficient evidence that that should be used that way at this point. Excitingly, in my mind, in 2023, the New England Journal of Medicine published a study, the ELECT-D trial, where they did ketamine and ECT head-to-head, and they found that ketamine was non-inferior to ECT as therapy for treatment-resistant depression without psychosis. So we'll talk about how psychosis can be an exclusion factor for ketamine. ECT can continue in somebody with major depressive disorder with psychosis. Similarly, acute suicidal ideation, ECT can be efficacious in this as well. Ketamine seems to be faster acting than ECT in reducing suicidal ideation, but as you continue to increase the time of frequency outside of treatment, ECT probably gains ground and overtakes the effectiveness of that we see initially by ketamine. So kind of the conclusion of this is, you know, ketamine of these articles were maybe try ketamine therapy first, see how somebody does. Then if they still haven't responded to the full nature, then try ECT after. And again, somebody with PTSD, think about ketamine. Somebody with anxiety spectrum disorders, think about ketamine. So exclusion criteria, who should we really think about not giving ketamine to? Pregnancy for obvious reasons, psychosis. Now we will talk about how schizophrenia and ketamine research are ongoing. And so it's probably more poorly controlled psychosis that we want to be prevented of, but it's good to be conservative in this area right now. Dementia, traumatic brain injury, substance use disorders, uncontrolled hypertension, or really any kind of cardiovascular disease, AV malformations, increased intracerebral hemorrhage or history of hemorrhage. And really the ideas there is, remember, ketamine is a stimulant or a stimulant effects. And so it's really can really increase somebody's blood pressure and the pressure that is throughout the cardiovascular system. And so anybody that's already sensitive to that can cause medical emergencies within that. Which is the supervision that's required a lot of times with these medications. Anybody that's had hypersensitivity to ketamine in the past, and then 18 years and older. And this is asterisk because really in behavioral health, we're seeing it in adults. Ketamine can be used to 3 months and older, and a lot of that's medical uses. And so the psychiatric research hasn't caught up really a lot with adolescents and children because, one, it's difficult to do studies on children for psychiatric reasons, but that's why that's asterisk. And then bipolar disorder, we'll talk about just briefly about the reasons that we're still hesitant with ketamine and bipolar disorder. So just real briefly, since we've talked about this a lot already, antidepressant effects, anti-suicide reduction in ketamine and major depression. We're seeing glucose metabolism in neuroimaging studies. So think of it this way. So we can look at nerve cells, and when nerve cells, they need glucose to survive. That's their fuel. When it's a healthy, plump brain tissue, a lot of good nerve cell connection, we're going to see a lot of glucose metabolism on neuroimaging. When it's depressed, stress, trauma, damage, strokes, whatever, we don't see much glucose metabolism because the neurons are dead. We're seeing through these studies that ketamine is increasing glucose metabolism, which supports the increasing connection and the health of neurons and the growth of the connections between the two. And ECT again, right? So let's say somebody has ECT, but has ECT resistant depression. So they're not responding to ECT. There's some emerging evidence that supports ketamine is going to be better in these cases as well. And maybe they'll respond to ketamine. We talked about the suicidality. I'm not going to keep beating this to death, but it's important to understand. And the last bullet point here is bolded. Anytime any scientist or physician can put all at the start of a sentence is pretty strong, but all meta-analyses and systematic reviews concluded that ketamine treatment was associated with a moderate to large decrease in suicidal ideation. So let's talk a little bit about ketamine and PTSD. So the postulation is that ketamine may be useful in preventing the development of PTSD through induction of stress resilience. In my mind, the evidence of proof of that still needs to be borne out, but we're seeing positive results for sure in a lot of areas. The only pharmacological treatment, right? There's many effective psychotherapeutic treatments, but the only pharmacological treatment approved for PTSD by the FDA are SSRIs. But this is just maintenance therapy. We're just controlling symptoms. We're not helping remission. One study evaluated efficacy of ketamine use in the treatment of chronic PTSD, and they saw some good things in that study. There was a prompt reduction in intrusion, avoidance, and negative mood and cognition symptoms throughout a 2-week period of time. And then the last bullet point, there's a dramatic reduction post-ketamine infusions or treatment in inpatient psychiatric hospital stays. So patients aren't severe enough to need to go to the psych hospital, or excuse me, the days are shorter, so the disease burden isn't as severe, so they can discharge sooner. And then also the admission rates are decreased as well, up to a 65% reduction rate. So that's significant and something that is definitely exciting and continuing to be watched. So it's a drug. Ketamine is a drug. Ketamine has tons of great things. There's tons of reasons to be excited about it, but we need to understand there's reasons that we don't always hear the bad stories. And there are patients that can't tolerate it, don't like it, and that very much exists. This isn't all the things that I could have listed, but it's a lot of them. I'm just going to talk about the bolded lines here. Death by overdose is rare with ketamine and usually involves other intoxicants or in the setting of trauma. And most popularly, Matthew Perry in this setting, the autopsy was acute effects of ketamine was the cause of death. However, he also had buprenorphine and lorazepam in his system. And so, excuse me, anytime that we're combining an opioid like buprenorphine and benzodiazepines, we're increasing the risk of respiratory depression significantly. And so was this enough, to help the breathing to stop and drown? We don't know. I think what it also echoes is we need ketamine. Somebody getting ketamine has to be in a supervised, controlled environment. The next bolded line, recreational ketamine use can cause mood changes, including depression and irritability. So recreational use could be causing the exact thing that we want to treat and make it better. So we need to be aware of even somebody taking ketamine. Are they getting better? Are they getting worse? Like we need to maybe take a further look at what their diagnosis is, what else is going on, right? So having a cautious eye to this. The next one, emerging evidence suggests ketamine is becoming more widely used as a recreational substance. Tell as old as time, right? We've seen this historically. It's happened every time ketamine's become more mainstream, more abuses happened. Medscape Medical News found that ketamine poisonings in the US have increased 81% between 2019 and 2021. Again, needs to be supervised, needs to be controlled, and we need to do right by patients. And then the last one, interactions. We have to be aware of patients using alcohol, opioids, benzodiazepines, and cannabis because the interactions to ketamine can cause problems. To put a finer point on it, anybody with cardiovascular disease, poorly controlled hypertension, like we talked about, increasing pressures, we don't want to do ketamine. If it's kind of in the gray zone and we're unsure, cardiology consult is probably warranted in making sure that they approve. Anybody with increased intracranial interocular pressure, we don't want to do anything with. However, there is some emerging evidence that maybe ketamine is even helpful in those states, but more to come on that. Poorly controlled psychosis, we don't want to develop more hallucinations, more dissociative state, more distortions of reality than somebody maybe already has. Severe liver disease, such as cirrhosis. Remember, even though ketamine doesn't maybe necessarily pass through the liver for metabolism initially, eventually it has to be metabolized to leave our body. And so if the liver is not able to do its job, concentrations of ketamine can increase, causing more higher of a dose. And then pregnancy, again, active substance use disorder. And so maybe this is the delineation between historical substance use disorder. But I think what's failed to be shown yet is how long of sobriety needs to be had before we even want to think about giving ketamine to somebody. Is it 3 months, 6 months, 9 months, 12 months? But if it's actively happening, we don't want to do ketamine. And then age less than 3 months. So further experimental uses, I've already alluded to a lot of these. Bipolar disorder, the thing that we worry about with ketamine at this point is inducing mania. That's a psychiatric emergency. We don't want that happening. Substance use disorders, we've talked about. Anxiety spectrum disorders. It has shown some improvement with generalized anxiety disorder, some OCD, social anxiety, panic disorder. Eating disorders is another interesting space for ketamine. To date, we haven't really, a lot of it's focused on anorexia nervosa. We haven't seen a lot of improvement in the eating disorder symptoms itself. And so ketamine's still being used the way we'd be using it in somebody else, kind of the psychiatric comorbidity surrounding it, and then schizophrenia. So let's transition to kind of what to expect when somebody comes to get ketamine, right? So they're going to need to come, somebody's going to need to take them to the clinic, and they're going to have to leave with somebody from the clinic. They can't drive, and preferably not by an ambulance like the icon here. I just didn't have another vehicle for it. And then the waivers and documentation, we need to let people know they have to be signing that they're not going to be driving, that they understand the risk, that the other forms other than intranasal are not FDA approved. A healing, tranquil space, right? This should be a whole experience for the patient. It should not just be about ketamine, but the experience around ketamine. What are they learning from ketamine? What are they learning about themselves? Kind of digging deeper. Blood pressure, we're monitoring before treatment, 40 minutes into treatment, post-treatment. And really, if somebody has a high enough blood pressure before, we're not going to continue with giving them ketamine, and maybe have to go see their primary care physician to get treatment first. To help with the meditation, mindfulness aspect, journaling, meditating, vibroacoustic therapy, lying down. We're going to talk about psychotherapy adjuncts, but really this whole experience needs to be around ketamine as a whole. Most adverse effects that somebody's going to have from ketamine are going to be mild and resolve pretty quickly. There is going to be some cognitive deficits, though, especially within 2 hours, and typically takes about 24 hours to fully resolve. And so some people may talk about decreased attention, maybe some executive functioning, so some planning difficulty, which is why we don't want them driving, some verbal memory issues. Patients may get dissociative effects on the first one. It may become more common as they get more treatment. But again, even if they're not having it, ketamine is still working on the neurons. And then some physical side effects, the lightheadedness, dizziness, some sedation, tiredness, nausea, vomiting can be helpful, can happen. But how that's going to affect people really is individual to people, and can be dose dependent as well. This slide talks about tolerance. So I think one of the things that people are worried about beyond what's going to happen neuropsychiatrically to somebody with long-term ketamine use, is ketamine going to stop working? There's some studies, again, that show, yeah, within about 6 weeks, they can develop tolerance and it stops working. However, there's other studies that show there's been no tolerance development, and through long treatment period options. So again, this reiterates, hey, we need more research into all of this to help us with the dosing, the type of ketamine to give, and how long should we be giving ketamine. So with therapy, this idea of ketamine-assisted psychotherapy, there's a lot of evidence to both the therapeutic support and the setting at which ketamine is happening definitely is part of the longevity of the ketamine effects. So we believe that needs to happen. And then there's this dose dependency probably as well. Like, what's the patient, what's the therapist, what are they looking for, what have they agreed to? Because at lower doses of any form of ketamine is probably going to be that more active therapist-patient communication. The patient's going to be more grounded. And the larger doses of ketamine, there's going to be more of that psychedelic psychotherapy, more inward focus, eye coverings, music. Therapists will talk about there's some advantage of doing. So you get some form of ketamine, and then you're doing therapy during that 2-hour period, or you're doing therapy during that 2-hour period. There can be some advantages with that. I've talked to a lot of therapists, though. It seems to be that more of having the patient journal during those 2 hours, having them be with themselves during those 2 hours, having them come back the next day, and then have that therapy session seems to be more positive, because the patient has a lot of reflections. They're thinking about what they went through, and they're able to talk through that from a grounded state. So we talked about the gaps in research, and I only have 2 more slides and I'll take questions. There's gaps in research that we've talked about, but there's also the placebo effect that we have to be aware of. And the psychological component of medication treatment, especially in psychiatry, especially for depression, can be a lot, right? Up to half of treatment outcomes are related to placebo when we look at historical depression treatment with medications. This is not to say that ketamine is not working. I've seen it work. I know it's working. There's a lot of strong placebo-controlled trials that are showing that ketamine is working. It's just something that we need to be aware of the full story. And then lastly, I'm a big ketamine fan. I'm a big psychedelic fan done right, and learning about it, but there's more that we still need to know. And we should be constantly seeking for that evidence and for those understandings. Ketamine works on many areas of the brain. what are the downstream effects? What are the short-term, long-term effects? How long should we be doing this? But there's a lot to be excited about. And I will stop sharing my screen and we'll take questions.
All right, we had lots of great questions. And I want to thank anyone who has to leave. I'm going to keep the recording going while he answers these questions so that you can listen to them later. The question was, why would people be using it for illicit purposes? Like if you're talking about these dissociative effects.
Well, I mean, so it's a psychoactive component that's working on the dopamine system of the brain. And anytime that we work any type of medication or a drug works on that area of the brain, certain people are susceptible to abuse. And so it's not necessarily the symptoms themselves that patients are craving or people are craving. It's more of what's happening physiologically to them that's increasing the use and the abuse.
Right. Does ketamine affect the serotonin levels?
It can, but not to a significant enough area that we're worried about serotonin syndrome, for example, on patients that are already on serotonin medications.
Is BDNF testable?
Yeah, so there are markers for BDNF. I am not 100% sure on the reliability of those testings. But yeah, there are markers. So a lot of when we start looking at kind of these neuroproteins, neurochemicals, you can test for a lot of things. I think if you dig deep into those, the research on them, not everybody's going to agree upon what's been concluded there.
Awesome. How are the long-term effects of ketamine for depression?
I've seen a lot of it vary. I've had patients who have had a month to 2 months of ketamine and have not needed it again and have done well and have been off medications. I've seen people use ketamine and stay on medications but have a better overall functioning. I've seen patients that hate ketamine. They get really sick even when we try to treat their nausea. They don't like the experience of losing control of themselves. There could be some stigma that they don't like. So it's kind of across the board, but in my opinion and talking to colleagues and things, it's definitely a more positive than negative at this point, and it's really shining light on people that have needed help for so long that are finally getting it, and I think that's the most exciting and rewarding part.
What doctors are trained in ketamine applications? Psychiatrists, neurologists, I know anesthesiologists.
Yep. Yeah, that's a good question. So psychiatrists for sure, of all the psychiatric spaces and ketamine. Now, if they get training, right? This is all post residency, post fellowship things, although there's, you can learn during that time too, but this is kind of ongoing learning that's happening. When you start to get to the IV ketamine part and you're starting to have to manage advanced cardiac life support medications and things, you really want somebody that's more trained in advanced cardiac life support. So that's anesthesiology, emergency medicine, critical care physicians, kind of the physicians or like CRNA, different types of nurse practitioners that have treated that in the medical fields are very equipped at watching the medical. So really watching the medical side of ketamine and the psychiatric side of ketamine are kind of the people you want involved.
Awesome. There's a couple with mental health of young adults at an all-time low. Can you comment on the current standard of practice on using ketamine on young adults?
Yeah, I think again, this goes to the relationship that you have with patients. In my mind, I'm using 18 years and older. Kind of depending on the course of their life, like have they had depression for most of their life, or is this the first episode they've had depression? Did somebody pass away? Did they have a breakup? Kind of what is the extenuating circumstances of their depression? Like all these things matter to me. How many medications have they had? So if I have a patient that the depressive burden is really high in them, they have a huge family history of it, maybe have suicide attempts or completed suicides in their family, I may be thinking about ketamine earlier in that case. If somebody just, has gone to college and they're having trouble transitioning to college and growing up and going out of the house and they haven't tried any psych meds yet, I'm probably trying a psych med first, right? Because I'm thinking about I don't think this person's going to abuse it, and I don't think they're going to have any problems with ketamine, but you never know. And so maybe we start at a lower risk type of thing. But again, I think this is all patient provider dependent and kind of the relationship that's there.
It's a really great question. Can you share a little more about psychedelics and ketamine for those in recovery from an SUD? How do you evaluate the risk versus the benefit?
Yeah, I mean, this is the forefront of where we're at right now. I think we're trying to wrap our head around this. Um, I'm myself and a lot of colleagues are on the conservative side of this, that if somebody has a substance use disorder, we're not thinking about ketamine. And I've had patients who've been sober for 14, 15 years. And I have that conversation with them, and we really talk about, like, these are the risks, and I don't know if this is gonna, have develop into a relapse, wetting the nucleus accumbens and the dopamine systems of the brain and kind of all this happening again. It's a risk, right? And I think we don't fully understand what is the length of time of sobriety that needs to happen to safely give ketamine again, to not have relapse happen. What I can say is anybody that's actively using substances should not be getting ketamine.
And does that go for marijuana as well?
So, yeah, it's that's the very tough discussion with it being legal and all these things. What we want people to do is abstain from using marijuana. If marijuana is the only substance that they've ever used and that they're abusing, we don't want them using marijuana during the time that they're getting ketamine.
Interesting. How does a clinician prove or document treatment-resistant depression, since there's no DSM code for that? Do ketamine clinics ask for letters or something? And does the client just get a reassessed or re-diagnosed directly by the clinicians once referred there?
Yeah, so essentially, any ketamine place that's giving ketamine, really the patient should have their own psychiatric evaluation at that setting. And so at that setting, the psychiatrist, nurse practitioner, psych PA, whoever is going to really be asking about past psych history and really delving into past medication trials. And this really is, if we're wanting insurance to help cover this, it's going to be really important to know what they've tried before. And so kind of really taking the patient at their at their word of that. If we're suspicious of the patient, then we're definitely going to get further collateral from the referring treatment team, really making sure that we understand what their history is. But so that's really the thing for treatment-resistant depression.
Great. As a person interested in self-introspection and access to unconscious thoughts and paradigms, would ketamine be a recommended resource?
Yeah, I think, and so this is the other conversation of psychedelic medication. So I think there's a space for all of that, right? As a physician, somebody who is controlled by the DEA, who has state licenses, who pays malpractice, there's going to be a harder time to get those types of providers to prescribe, because this has to be prescribed, to prescribe it for kind of those instances without a DSM diagnosis, without kind of a real indication that has been laid out to this point. I think while I think the social awareness and acceptability of doing these things is moving in that direction, I think the medical legal system is going to be a lot slower with that, which I'm bound by, which is always the concern that I have in that space. But I get the question. It's just it's a difficult space.
Thank you. There's a few more questions if you have time.
Sure.
Is there any evidence to support benefits from a single session, or is there greater recommended number of treatments?
There isn't. The most of the research is going to indicate that you're going to need repeated sessions. Now, how many? That's up for debate. And that doesn't take away the benefit of a single dose. Okay. But what we're seeing, again, remember the connections of neurons, and we're trying to create neurogenesis and create a healing environment. It's probably going to take more than one session. And that's kind of borne itself out through the literature. But how many we need, that is still under investigation. But I have not known anybody that's done one session and no more and has had full relief.
Great. Here's an interesting question. How likely are patients who are undergoing low-dose KAP to be able to engage in talk-based therapy during that session?
And so typically those patients are going to do it the next day. Now there are, depending on the patient, right? There are some patients who don't have a lot of dissociative effects or a lot of effects that separate them from reality. They may not feel much of it whatsoever, feel it. And those patients are going to be pretty grounded in reality and can engage in that talk therapy. Patients that have more of that dissociative state, patients that have more of that the disruption of reality, if you will, are going to be better to kind of journal what their experience is and bring that to them the next day or the next week. I think the next day is preferable, but within that next week.
Great. You mentioned poorly controlled psychosis. Would you ever use ketamine for somebody who has had experienced psychosis?
Yeah, I mean, psychosis is not created equal, right? There's pseudo hallucinations and a variety of diagnoses. But if somebody has real psychosis from either a really bad depressive episode, bipolar episode, schizophrenia, schizoaffective disorder, no, I probably would not.
Why is it not
Unless I knew a lot more about them.
Can you say more about the treatment of trauma with ketamine?
Yeah, I think there's a lot of positive momentum that it's helping patients from a psychological aspect kind of reprocess their trauma, maybe think of things differently. Maybe it helps them see something they didn't think about before. So from a psychological standpoint, it's creating a window into that space that maybe defense mechanisms are up without the ketamine. I think from a biological standpoint, we're regenerating neurons. And so where trauma is going to damage neurons and damage brain cells and brain areas, we're providing healing to that. And so the more that we can heal the brain, somebody who maybe had a dysfunctional brain from trauma is going to have a hard time fully integrating psychotherapeutic effects, mindfulness effects. A fully formed, healed brain is going to maybe take that same modality and have a lot more effect from it.
And is there a reason that you're not recommending ketamine use with people with bipolar disorder?
Yeah, so I didn't put the studies in there, but there's still some concern. Now there's people that are doing it. There's still some concern of inducing mania in somebody with, so the antidepressant effect of ketamine inducing mania and bipolar disorder. A couple of the studies, some studies showed that, manic symptoms would happen within an hour to 2 hours post ketamine infusion, but typically resolve within that 24 hours. However, those studies that are showing that are underpowered, so it's not statistically significant. So in my mind, if something like ketamine can already induce manic symptoms within an hour or 2 hours post, the likelihood of that happening can be increased. And I have no ability to say if it's going to be 1 hour, 2 hours, what's going to happen within that 1 hour, 2 hours, right? Manic symptoms, a full manic episode can be a psychiatric emergency. And so really understanding, are you equipped at your clinic to handle that? Does the patient know the risks of that? I think there's still a lot to be known. More research needs to be had in bipolar and ketamine.
Awesome. There's one final thought. This woman, Julia, works with burn patients, and she said that they've been intubated and ketamine would help the patients forget the pain that the burns and this caused. So decreasing pain with PTSD, have you used it in that situation?
No, I mean, so that makes total sense to me. The analgesic effects of ketamine are very well established throughout the medical literature and has been used in those ways. To say to use ketamine for physical effects of pain or even emotional pain in PTSD is probably a step too far at this point versus what the literature supports. I don't think it's a bad idea. I think there's probably going to be some effect that we're going to see of some alleviation of that with ketamine and those types of symptoms and that pathology. But I think to this time, I think it's a step too far based on kind of what the literature supports.
Well, Dr. Zehring, this has been really, really insightful. And over in the chat, everyone's saying thank you very much for all of this information. And we appreciate your time because we know how busy you are. And this was really wonderful. Thank you.
Thank you all. Appreciate it.